Welcome back to the deep dive. Today, we're tackling a gland that punches way above its weight, the thyroid. Tiny gland, massive impact.
Absolutely. It's the body's thermostat, its engine controller, really. But the real challenge, and honestly where things get dangerous, is that thyroid problems are, well, they're masters of disguise.
Right. We're not just talking about a lump in the neck people can feel.
No, far from it. Think about fatigue that looks exactly like postpartum depression or cognitive issues in an older person that get brushed off as just early dementia. Maybe muscle weakness that seems purely neurological.
So our mission today is pretty critical. We've got a wealth of information here covering everything from, temporary flare-ups to genuine crises.
Yeah.
We need to tease out those subtle clues.
That's the goal. We're hunting for those diagnostic, tells the specific lab patterns, the physical exam findings, the context that let you confidently say, okay, this is thyroid versus this is something else mimicking it.
And it often comes down to a core mechanism, doesn't it? Is the thyroid actually churning out too much hormone, or is it just leaking, damaged and leaking?
Precisely. That's the fundamental split. Is it oversynthesis or is it release from damage? Getting that right changes everything for treatment. It's the cornerstone.
Okay, let's unpack this. We'll start with that second category first, the release mechanism. The transient thyrotoxicosis conditions. This is often where the first diagnostic fork in the road appears.
Right. So when you encounter someone with hyperthyroid symptoms, racing heart, weight loss, anxiety, the very first thing you have to figure out is the factory working overtime or is the warehouse just spilling its contents?
The synthesizers versus the leakers.
Exactly. And this whole first section is about the leakers. These are inflammatory conditions, thyroiditis, where the thyroid cells, the follicles, get damaged. And when they break open, they release the hormone that was already made and stored inside, T3 and T4.
So the person feels hyperthyroid because their system gets flooded with this stirred hormone, but the thyroid gland itself isn't actually stepping on the gas. It's not actively making more.
Correct. It's actually often shutting down production because of the inflammation or the feedback from all that circulating hormone. And this is where the radioactive iodine uptake scan, the RAIU, becomes, well, it's absolute decider.
Because if the gland isn't making new hormone, it doesn't need iodine, the raw material.
Precisely. You give the radioactive iodine, and the inflamed, leaky gland basically says, nope. Not interested. So the uptake is really low, usually less than 5%. That low uptake is the smoking gun for inflammation and release.
Makes total sense. The gland's effectively saying, I'm damaged and spilling. Why would I take in more supplies? Okay, let's look at the first one in this group. Painless thyroiditis, sometimes called silent thyroiditis.
Yeah, this one's interesting because it's actually considered a variant of Hashimoto's thyroiditis.
Which we usually think of as causing hypothyroidism, the slowing down.
Right. But in this case, the initial autoimmune attack causes this mild transient inflammation. It damages the follicles just enough to let that preformed T3 and T4 leak out, causing a temporary hyperthyroid state thyrotoxicosis.
But it's not a huge dramatic inflammation.
No, that's key. Clinically, you usually see it in young or middle-aged women. The hyperthyroid symptoms are often quite mild, maybe some palpitations, feeling a bit warm, losing a little weight. And crucially, the thyroid gland itself is usually small, maybe slightly enlarged, but it's non-tender, no pain.
And no eye signs like bulging.
No exophthalmos, no lid lag. That points away from Graves' disease. So you've got the high free T4, maybe high T3, a suppressed TSH, and that critical low RAIU.
And if the RAIU is low, we know it's release, not synthesis. So those antithyroid drugs, the ones that block synthesis,
are completely useless here. They don't work because there's no new synthesis to block. It's self-limiting. The inflammation runs its course. The leaked hormone gets metabolized. So treatment is just supportive. Beta blockers, like propranolol, are great for controlling the symptoms, the tremor, the fast heart rate, while the body sorts itself out.
Okay, now a specific variant of this that presents in a really challenging context. Postpartum thyroiditis, PPT.
Pathologically, it's the same mechanism that autoimmune inflammation, the hormone release. But the trigger, or rather the timing, is the defining feature. It happens within 12 months after giving birth.
And this is where the mimicry gets really dangerous, isn't it?
Devastatingly so. The typical course often starts with that transient hyperthyroid phase, maybe 2 or 3 months postpartum. The new mother feels anxious, jittery, maybe losing weight too fast, fatigued.
Which could easily be written off as just new mom stress or sleep deprivation.
Exactly. And then often it shifts. The inflammation burns out and the gland might become temporarily underactive, leading to a hypothyroid phase. This can last for months.
And the symptoms of that phase.
Profound fatigue, weight gain, or inability to lose baby weight, brain fog, constipation, feeling cold, depressed mood.
That sounds almost identical to classic postpartum depression, PPD.
It overlaps incredibly closely. This is why it's absolutely non-negotiable. Any woman presenting with significant fatigue, mood changes, or cognitive issues within that first year postpartum must have a full thyroid panel TSH and free T4 at minimum. You have to rule out PPT before jumping to a PPD diagnosis.
Because PPT needs hormonal treatment, levothyroxine, not just antidepressants or therapy typically used for PPD.
Correct. The diagnostic markers are the same as painless thyroiditis, low RAIU during the thyrotoxic phase, and often positive anti-TPO antibodies, linking it back to that Hashimoto's spectrum.
Such a crucial point for anyone caring for new mothers.
Okay, let's hit the last one in this trio, the one that definitely doesn't fly under the radar. Subacute thyroiditis, also called de Quervain's.
If the first two were silent or quiet, this one is loud. The defining feature is pain. The thyroid gland is exquisitely painful and tender to touch. Not just a little sore.
No, often it's severe pain, classically radiating up towards the jaw or the ears. Swallowing can be agony.
And what sets off this fiery inflammation?
There's usually a very strong history of a preceding viral upper respiratory infection, URI, a cold, the flu, something like that. It seems to be a post-viral inflammatory reaction that just hammers the thyroid follicles, causing widespread destruction.
So the patient feels systemically unwell, not just a sore neck.
Oh, definitely. They often have high fevers, chills, severe malaise. They feel really sick. It's an acute illness picture.
And that systemic inflammation shows up in the blood work differently too, right?
Absolutely. You'll see markedly elevated inflammatory markers like the ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein. These are usually sky high, which helps distinguish it from the painless forms.
But here's the key consistency tying it back to the others. The mechanism is still damage and release.
Exactly. It's follicular destruction causing leakage of stored hormone. So despite the dramatic symptoms, the RAIU scan will still show low uptake. The factory isn't overproducing, it's just being destroyed.
So the treatment reflects the pain and inflammation.
Yes. NSAIDs are first line for the pain. Beta blockers for the thyrotoxic symptoms. If the pain is really severe, incapacitating, then a course of glucocorticoids like prednisone might be needed to quickly shut down that intense inflammation. But again, antithyroid drugs, pointless. You manage the fire until it burns out.
Okay, so we've established the leakers, the thyroiditis conditions where inflammation causes hormone release and the RAIU is low. Now let's shift gears to the other side. Conditions where the thyroid gland itself is genuinely overactive, actively synthesizing too much hormone.
Right, this is the factory in overdrive scenario. And because the gland is actively making hormone, it's hungry for iodine. So the hallmark here is a high RARU. The gland avidly takes up that radioactive iodine tracer.
And the classic example, the most common cause of this type, is Graves' disease.
Yes. Graves is an autoimmune condition, but instead of attacking and destroying the gland like Hashimoto's eventually does, it stimulates it. It's caused by antibodies, TSH receptor antibodies, often called TRAB or TSI, that bind to the TSH receptor on the thyroid cells.
And they basically mimic TSH, telling the gland to produce hormone constantly.
Exactly. They hijack the control mechanism. The pituitary is screaming, "Stop!" by suppressing TSH production, but the gland ignores it because these antibodies are flooring the accelerator. You get that classic triad: suppressed TSH, high free T4 and T3, and a diffuse high RAIU. The whole gland lights up on the scan because it's all working overtime.
And Graves has those characteristic features beyond the thyroid itself, most notably the eye disease.
Graves' ophthalmopathy, yes. Those same TRAB antibodies unfortunately also target receptors on fibroblasts and tissues behind the eyes in the retroorbital space. This triggers inflammation, swelling, and tissue remodeling.
Leading to proptosis, the bulging eyes, and that characteristic lid lag where the eyelid doesn't follow the eyeball smoothly when looking down.
Correct. And this leads us to a really critical management point, a warning, really.
About radioactive iodine, RAI therapy.
Yes. While RAI is a definitive treatment for Graves' hyperthyroidism by destroying thyroid tissue, it can paradoxically worsen existing Graves' ophthalmopathy.
Why would that happen? Killing the thyroid makes the eyes worse.
The thinking is that when the RAI destroys thyroid cells, it releases a flood of thyroid antigens into the system. This can cause a temporary flare-up of the autoimmune response, leading to an increase in those tree of antibodies, which then attack the eyes more aggressively.
So if someone already has moderate or severe eye involvement,
RAI therapy is generally contraindicated, or at least used with extreme caution, maybe with concurrent steroid cover. The safer options in that scenario are the antithyroid drugs, methimazole or PTU, or thyroid surgery, thyroidectomy.
And methimazole is often the first choice, especially maybe in older patients or those with heart problems.
Generally, yes. It's easier to dose, usually once a day, and has a slightly better safety profile than PTU long-term, except in the first trimester of pregnancy where PTU is preferred. And speaking of the heart, thyrotoxicosis is incredibly tough on the cardiovascular system.
You see that bounding pulse, the high blood pressure.
You get significant systolic hypertension and a very characteristic wide pulse pressure. That's the difference between the systolic top number and diastolic bottom number pressure.
Why does that happen?
The excess thyroid hormone increases the heart's contractility. It pumps harder, leading to a high systolic pressure, but it also decreases systemic vascular resistance. The blood vessels relax, leading to a lower diastolic pressure. So high top number, low bottom number equals wide pulse pressure.
And the risks aren't just high numbers, right?
No, the major dangers are cardiac arrhythmias, especially atrial fibrillation, AFib, which significantly increases stroke risk. You can also see angina, worsening heart failure, or even high output heart failure, where the heart simply can't keep up with the body's supercharged metabolic demands. Controlling the thyroid is vital for protecting the heart.
Okay, moving away from diffuse overactivity, what about localized problems, like toxic nodule hyperthyroidism?
Great, this is different from Graves. Here, you have one or sometimes multiple nodules within the thyroid that have essentially gone rogue. They develop a mutation that allows them to produce thyroid hormone completely autonomously, ignoring the body's TSH signals.
So the TSH from the pituitary is suppressed because the body senses enough hormone.
Exactly, TSH is low. But the nodule itself keeps churning out T4 and T3. When you do the RAIU scan, you see a very different picture than Graves'. Instead of the whole gland lighting up, you see focal uptake, one or more distinct hot spots corresponding to the overactive nodule.
And the surrounding normal thyroid tissue.
It looks cold or suppressed on the scan because the low TSH has shut it down. It's a very clear visual distinction.
Now, if a patient has a thyroid nodule, the big fear is often cancer. What about these hot nodules?
That's actually the silver lining here. Hot nodules are almost never malignant. The autonomous function strongly suggests a benign process, like a toxic adenoma or multinodular goiter. Cold nodules, the ones that don't take up iodine, are the ones that carry a higher risk of malignancy and need further investigation, usually with a biopsy.
Okay, good to know. But even if it's benign, letting that toxic nodule just keep pumping out extra hormone isn't harmless.
Right.
There's a long-term consequence.
Absolutely. Any cause of chronic, untreated thyrotoxicosis, whether it's Graves' or a toxic nodule, leads to accelerated bone turnover. It basically puts your skeleton into overdrive.
Stimulating the cells that break down bone.
Precisely. It ramps up osteoclast activity, leading to significant bone loss over time and increasing the risk of osteoporosis and fractures. Even if the hyperthyroidism feels mild symptomatically, protecting bone health is a key reason to treat it effectively.
Okay, now for a real curveball, the scenario where the TSH level throws you off completely. Secondary hyperthyroidism.
Ah, yes, the TSH paradox. This is where you must think centrally, meaning the problem isn't in the thyroid gland itself, but higher up in the pituitary.
How does that present? What's the paradox?
In all the primary hyperthyroidism we've discussed, Graves', toxic nodule, the thyroid is overproducing, so the pituitary senses this and suppresses TSH. TSH is low or undetectable. But in secondary hyperthyroidism, you have high levels of free T4 and T3, but the TSH level is inappropriately normal or even elevated.
Wait, so the body is flooded with thyroid hormone, but the pituitary is still sending the make more signal, TSH. The feedback loop is broken.
Exactly. The negative feedback is completely overwritten. This almost always points to a TSH-secreting pituitary adenoma, a tumor in the pituitary gland that's pumping out TSH uncontrollable.
So if you see that lab pattern high T4, T3, and non-suppressed TSH, you have to investigate the pituitary.
Immediately. And because these adenomas are often large enough to cause physical compression, you need to look for clinical signs of mass effect.
Like headaches, vision problems.
Yes, persistent headaches are common. And compression of the optic chiasm, where the optic nerves cross, can cause characteristic visual field defects, classically bitemporal hemianopsia, loss of the outer peripheral vision in both eyes.
So the treatment obviously isn't targeting the thyroid here.
Absolutely not. Giving antithyroid drugs might lower the T4, T3 temporarily, but it doesn't address the underlying pituitary tumor. The definitive treatment is neurosurgical, transnodal resection to remove the adenoma, recognizing that TSH paradox is critical because it completely changes the diagnostic pathway and the required intervention.
Okay, we've covered the overdrive states. Now let's hit the brakes and talk about hypothyroidism, the systemic slowdown. And just like hyperthyroidism, it's a master of disguise, often mimicking neurological or psychiatric conditions.
It really is. The effects are so widespread because thyroid hormone is needed by practically every cell in the body. Let's start with the muscles, a really common area of confusion. Hypothyroid myopathy.
So this isn't just feeling tired, it's actual muscle dysfunction.
Yes. Patients complain of proximal muscle weakness, difficulty climbing stairs, getting up from a chair, along with muscle aches, myalgias, cramps, and fatigue. Super common symptoms.
Sounds like it could overlap with lots of things, fibromyalgia, just getting older, being out of shape.
It definitely can. But the key physical exam finding, the classic sign, is delayed deep tendon reflexes. You tap the ankle reflex, for example, and you see a noticeably slow contraction and, even more characteristically, a very slow relaxation phase, sometimes called hung-up reflexes.
That sluggishness reflects the low metabolic state of the muscle.
Precisely. Energy metabolism within the muscle cell is impaired, and this muscle distress often shows up in the labs, too.
With creatine kinase.
Exactly. You'll often find an elevated creatine kinase, CK, level, sometimes significantly high, indicating muscle fiber breakdown and leakage of the enzyme. So the picture is proximal weakness, those classic delayed reflexes, and an elevated CK.
And the good news.
The great news is that this myopathy is completely reversible with levothyroxine treatment. As the thyroid levels normalize, the muscle strength returns, the aches resolve, and the CK level drops back to normal.
It's important to contrast that with hyperthyroid myopathy, right? That also causes proximal weakness.
Yes, but in hyperthyroidism, the reflexes are usually brisk, hyperactive even, and the CK level is typically normal. So the reflexes and the CK are your big differentiators between muscle weakness from too much versus too little thyroid hormone.
Okay, moving from muscles to the brain. Hypothyroidism can be a scary mimic here, especially at different life stages.
Definitely. In adolescence, hypothyroidism can easily be misdiagnosed as primary depression or even ADHD.
Oh, so?
The teenager might present with apathy, lethargy, poor concentration, falling grades, social withdrawal, all classic signs of depression. Or the difficulty concentrating might look like ADHD, but you have to look for the systemic clues of hypothyroidism, like bradycardia, a slow heart rate, constipation, feeling cold all the time, maybe some dry skin or hair changes, unexplained weight gain despite poor appetite. If those are present alongside the mood or attention issues, you must check thyroid function.
Because treating the thyroid deficiency could resolve the psychiatric symptoms entirely.
Often, yes. Levothyroxine can dramatically improve mood, energy, and cognitive function in these cases. It's crucial not to miss it before starting potentially unnecessary psychiatric meds. And then in older adults, the mimicry shifts towards dementia.
This is a big one, presenting as memory loss, confusion.
Yes, forgetfulness, slowed thinking, poor concentration, seeming cognitive decline. It can look very much like early Alzheimer's or other primary dementias. Again, you have to hunt for the systemic clues. The characteristic hoarseness of the voice due to fluid deposition in the vocal cords, constipation, weight gain, cold intolerance, puffy face, the slow reflexes we talked about.
And the absolutely critical point here.
The cognitive impairment caused by hypothyroidism is reversible with treatment. It's one of the few truly treatable causes of dementia-like symptoms. You cannot afford to miss diagnosing hypothyroidism in an older adult presenting with cognitive decline. Restoring thyroid levels can restore their cognitive function.
A massive potential impact on quality of life. Now let's connect the thyroid to the reproductive system. How does hypothyroidism cause abnormal uterine bleeding, AUB?
Okay, this involves understanding the hormonal cascade, the sort of chain of command. When thyroid hormone levels, T4, are low, the hypothalamus up in the brain senses this and releases more TRH, thyrotropin-releasing hormone.
Trying to stimulate the pituitary to make more TSH, to get the thyroid working harder.
Correct. That's the intended effect. TRH goes to the pituitary, and the pituitary increases TSH output. But TRH has a side effect. It also stimulates the pituitary cells that produce prolactin.
Ah, the hormone involved in milk production, but it does other things too.
Right. So in primary hypothyroidism, you often get both elevated TSH and elevated prolactin levels as a result of that high TRH.
And what does high prolactin do to the menstrual cycle?
Hyperlactin acts back on the hypothalamus and pituitary to suppress GnRH, gonadotropin-releasing hormone pulsatility. This, in turn, leads to decreased LH and FSH secretion from the pituitary.
The hormones needed for ovulation.
Exactly. Without the proper LH-FSH signaling, the woman doesn't ovulate regularly, anovulation. This disrupts the normal estrogen and progesterone cycling, leading to irregular menstrual cycles, often heavy bleeding, menorrhagia, or infrequent periods, oligomenorrhea.
So it's a domino effect starting from low T4.
It is. Low T4, high TRH, high TRH, high TSH, and high prolactin right arrow, suppressed GnRH right arrow, anovulation right arrow, AUB.
Wow. But the fix is elegant.
Very. Treat the underlying hypothyroidism with levothyroxine. This normalizes T4, which lowers TRH. Lower TRH means TSH normalizes, and prolactin normalizes. Normal prolactin allows GnRH, LH, and FSH to function properly, restoring ovulation and regular cycles. You fix the thyroid, you fix the period.
Fantastic. Lastly, in this section, let's touch on subclinical hypothyroidism and its impact on pregnancy. This is defined as elevated TSH but normal free T4, right?
Correct. The TSH is high, indicating the pituitary is working hard, but the thyroid is still managing to produce enough T4 to keep the free level within the normal range, for now.
Why is this particularly relevant for pregnancy, especially recurrent pregnancy loss?
The link is especially strong in women who not only have subclinical hypothyroidism, but are also positive for anti-TPO antibodies. These antibodies themselves, even independent of the TSH level to some extent, seem to be associated with an increased risk of miscarriage, potentially by affecting placental development or implantation. High antibody titers are a significant risk factor for recurrent pregnancy loss, RPL.
So if a woman has RPL or is trying to conceive, and she has both elevated TSH, even mildly, and positive anti-TPO antibodies,
then treatment with levothyroxine is generally recommended. The goal is to optimize maternal thyroid function, typically aiming for a TSH in the lower end of the normal range or pregnancy-specific range, to reduce the risk of miscarriage and support healthy fetal development.
All right, let's shift now to the real emergencies, the situations where immediate recognition and action are absolutely life-saving. First up, the hyperthyroid crisis, thyroid storm, or thyrotoxic crisis.
This isn't just bad hyperthyroidism. It's a catastrophic, exaggerated response. It's life-threatening metabolic decompensation. It typically occurs in someone with underlying, often untreated or poorly controlled, hyperthyroidism who then experiences a major stressor.
What kind of stressors can tip someone over the edge?
Things like severe infection, pneumonia, sepsis, major surgery or trauma, childbirth, diabetic ketoacidosis, or sometimes even a large iodine load, like from intravenous contrast dye used for CT scans. It's the stress on top of the hyperthyroidism that triggers the storm.
And the clinical picture is dramatic.
Terrifyingly so. Key features include extreme hyperpyrexia, very high fever, often over 38.5 degrees C or 104 degrees Fahrenheit, severe tachycardia, often way out of proportion to the fever, potentially with dangerous arrhythmias like AFib with rapid ventricular response. Significant CNS dysfunction is crucial, ranging from agitation, confusion, and delirium to psychosis, seizures, or even coma.
And cardiovascular collapse.
Yes, patients can develop heart failure, hypotension, and shock. Nausea, vomiting, diarrhea, and jaundice from liver dysfunction are also common. It's a multi-system meltdown driven by the massive surge of thyroid hormone effects.
This sounds like an immediate ICU admission.
Yeah.
What's the critical treatment approach? You mentioned a sequence.
Absolutely. Treatment must be fast, aggressive, and sequential. Getting the order wrong can be fatal. Think of it in 4 essential steps.
Okay, step 1.
Block the peripheral effects. Give a beta blocker, typically propranolol. It helps control the heart rate, tremor, and anxiety. Importantly, propranolol also has the added benefit of partially blocking the conversion of T4, less active, to T3, more active in the peripheral tissue.
Step 2, stop the factory.
Exactly. Administer ethinomide, either PTU, propylthiouracil, or methimazole in high doses. This blocks the synthesis of new thyroid hormone within the gland. PTU is often preferred initially in STARM because it also inhibits T4 to T3 conversion, giving it a slight edge, but methimazole works too.
Now, step 3 is where timing is critical, right? The iodine.
Absolutely crucial. About at least 1 hour after giving the thionamide, you administer an iodine solution like SSKI, saturated solution of potassium iodide, or Lugol's solution.
Why the delay? What does the iodine do?
The iodine works by the Wolff-Chaikoff effect. A high dose of iodine acutely inhibits the release of preformed thyroid hormone that's already stored in the gland. It basically slams the warehouse door shut. You must give the thionamide first to block synthesis, then give the iodine.
Because if you give iodine first,
The overactive gland might actually use that iodine as fuel to temporarily make even more hormone before the Wolff-Chaikoff effect kicks in. It's called the Jod-Basedow phenomenon. So
Call.
block synthesis first, then block release.
Got it. Block synthesis, wait an hour, block release. Step 4.
Glucocorticoids. High-dose steroids, like hydrocortisone or dexamethasone. These have multiple benefits. They further reduce the peripheral conversion of T4 to T3. They help stabilize the patient systemically, and critically, they treat potential relative adrenal insufficiency, which can coexist in severe stress states like thyroid storm.
So, beta blocker, thionamide, wait an hour, iodine, steroids, that sequence is key.
It's the mantra for managing thyroid storm.
Okay, now for a danger related to the treatment of hyperthyroidism. Antithyroid drug-induced agranulocytosis.
Yes, this is a rare but potentially fatal side effect of the thionamide drugs methimazole and PTU. Agranulocytosis means a severe drop in neutrophils, the main type of white blood cell that fights bacterial infections.
It essentially wipes out the patient's ability to fight infection.
Precisely. It leaves them incredibly vulnerable to overwhelming sepsis. It's an idiosyncratic reaction, meaning it's not related to the dose and can happen suddenly at any time during treatment, although it's maybe slightly more common early on.
What are the absolute warning signs every patient taking these drugs needs to know?
The cardinal symptoms are sudden onset of fever and sore throat. Sometimes painful mouth ulcers can also occur. Any patient on methimazole or PTU who develops these symptoms must be instructed to stop the drug immediately and seek medical attention.
What's the immediate medical action?
Stop the drug immediately. Get a WBC count with differential urgently. If the absolute neutrophil count is very low, typically 500 millimeter, confirming agranulocytosis, the patient usually needs hospital admission and empiric broad-spectrum antibiotics because infection is almost guaranteed and can rapidly become life-threatening.
And you can't just lower the dose if this happens.
Absolutely not. It's an allergic-type idiosyncratic reaction. Once it happens, the patient can never take that drug, or often the other thionamide either, again. They will need alternative treatment for their hyperthyroidism, like radioactive iodine or surgery.
Okay, we've covered overactivity, underactivity, and crises. Now let's delve into some really tricky areas, situations where the thyroid labs look off, sometimes way off, but treating with thyroid hormone would actually be wrong, even harmful. These are the major diagnostic traps.
Yes, this is where understanding the context and the physiology is paramount. Let's start with a very common scenario in hospitalized patients. Euthyroid 6 syndrome, ESS, also known as non-thyroidal illness syndrome or low T3 syndrome.
This happens in people who are critically ill, right? Sepsis, major trauma, post-surgery in the ICU.
Exactly. It's seen in the context of significant acute illness. And the lab pattern can be really confusing if you don't recognize it. The most common and earliest finding is an isolated low T3 level. As the illness gets more severe, the total T4 and free T4 might also start to drop, and the TSH can be low, normal, or sometimes slightly elevated later during recovery.
So low T3, maybe low T4, variable TSH. Looks kind of like hypothyroidism. Maybe even central hypothyroidism if TSH is low.
It can certainly mimic it, but the crucial difference is the underlying mechanism. ESS is thought to be an adaptive response by the body to severe illness.
Adaptive? How so?
During critical illness, the body tries to conserve energy and reduce catabolism, the breakdown of tissues like muscle. One way it does this is by decreasing the peripheral conversion of T4, the less active storage hormone, into T3, the highly active metabolic hormone. Inflammatory cytokines and caloric deprivation drive this change. It's the body deliberately putting the brakes on metabolism to survive the acute crisis.
So the body is intentionally lowering the active T3 level as a protective measure.
That's the prevailing theory. It's metabolic downregulation for survival.
Which leads to the most important management point.
Do not treat with thyroid hormone. Giving levothyroxine, T4, or leotheranine, T3 in this situation, might actually be harmful. You'd be overriding the body's protective mechanism, potentially increasing metabolic stress, protein breakdown, and oxygen consumption at a time when the patient can least afford it.
So the treatment is to treat the underlying critical illness.
Exactly. Focus on managing the sepsis, the trauma, the heart failure, whatever the primary problem is. As the patient recovers from that underlying illness, the thyroid hormone levels will gradually normalize on their own. You just monitor. You don't intervene with thyroid meds.
Okay, huge trap to avoid. Now let's revisit that low RAIU pattern. We saw it in thyroiditis. Where else can it pop up in a hyperthyroid picture?
In factitious thyrotoxicosis. This is hyperthyroidism caused by secretly taking thyroid hormone, usually L-thyroxine,
People deliberately taking thyroid pills they don't need. Why?
often for weight loss, unfortunately. It might be in unregulated weight loss supplements, or sometimes patients with diagnosed hypothyroidism might intentionally take more than prescribed. The lab results look initially like Graves. High free T4, T3, and a suppressed TSH because the body senses all the extra hormone.
But unlike Graves, the RAIU will be low, right?
Mm-hmm.
Because the thyroid gland itself isn't overactive, it's being suppressed by the external hormone.
Correct. The RAIU is low, usually near zero. But wait, we just said thyroiditis also causes low RAIU with high T4, T3, and suppressed TSH. So how do you tell the difference between inflammation-releasing stored hormone, thyroiditis, and someone taking pills, factitious?
Ah, this is where that other test comes in handy.
Exactly. You need to measure thyroglobulin. Thyroglobulin is the protein scaffold inside the thyroid follicles where hormone is made and stored. When thyroiditis damages the follicles and hormone leaks out, thyroglobulin leaks out too. So in thyroiditis, thyroglobulin levels will be high.
But if someone is just taking thyroid hormone pills,
There's no inflammation, no follicular damage, no release of stored material from the gland. The thyroid gland is suppressed and quiet. So in factitious thyrotoxicosis, thyroglobulin levels will be low, often undetectable.
okay, that's the key differentiator. Low RAIU plus high thyroglobulin, thyroiditis. Low RAIU plus low thyroglobulin equals factitious intake.
That's the fingerprint. And obviously, the treatment for factitious thyrotoxicosis isn't antithyroid drugs. It's stopping the exogenous hormone source and maybe using beta blockers for symptoms until it clears.
Brilliant. Okay, final trap. How do other hormones, specifically estrogen, mess with our interpretation of thyroid labs?
This is super common and important, especially with oral contraceptives, OCPs, hormone replacement therapy, HRT, and of course during pregnancy. Estrogen increases the liver's production of thyroxine-binding globulin, TBG.
TBG is the main protein taxi that carries thyroid hormone around in the blood.
Exactly. More estrogen means more TBG taxis. More taxis means more hormone gets bound up and carried around.
So if you measure the total amount of thyroid hormone, bound plus free,
The total T4 and sometimes total T3 level will be elevated. It looks like the person might be hyperthyroid if you only look at the total level.
but the amount of active unbound hormone, the free T4, isn't necessarily changed?
Correct. In a healthy person, the pituitary gland compensates. It senses the slight drop in free hormone as more gets bound to the increased TBG, and it nudges TSH just enough to make the thyroid produce a bit more T4, restoring the free T4 level back to normal. So the end result is elevated total T4, but normal free T4 and normal TSH.
And the patient feels fine. They're clinically euthyroid.
Yes, absolutely. Their metabolism is perfectly normal because the active hormone level, free T4, is correct.
So the rule is, if total T4 is high but TSH is normal, always check the free T4. Don't treat based on total T4 alone.
Never.
Okay.
Always rely on the free T4 or free T4 index and TSH for assessing thyroid status when TBG levels might be altered.
And this becomes critically important in pregnancy.
Hugely important. During pregnancy, estrogen levels soar, causing a big rise in TBG. Plus, the pregnancy hormone HCG can weakly stimulate the TSH receptor. Both factors increase the demand for thyroid hormone.
So a woman who already has hypothyroidism and is on levothyroxine needs more medication when she gets pregnant.
Yes, and usually immediately. The standard recommendation is for women with pre-existing hypothyroidism to increase their levothyroxine dose by about 25–30% as soon as pregnancy is confirmed. Often this means taking an extra 2 doses per week. Close monitoring of TSH and free T4 is then needed throughout the pregnancy. Failing to increase the dose promptly can lead to maternal hypothyroidism, which can negatively affect fetal brain development, especially in the first trimester. Hashtag outrarella.
Wow. We have really journeyed through the complexities of the thyroid today. From the gland leaking versus overproducing, to the mimics in the brain and muscle, to life-threatening storms and drug reactions, and finally these lab interpretation traps.
It really highlights how central this small gland is. If I had to boil it down to a few key takeaways for you, the listener. First, always remember the RAIU. Low uptake points you towards inflammation or exogenous intake. High uptake points towards Graves or toxic nodules. It tells you the mechanism.
Mechanism is everything.
Second, when you see symptoms that look psychiatric depression, anxiety, dementia, or muscular weakness, aches, always consider the thyroid and look for those systemic clues. The reflexes, the skin changes, the voice, the CK level. Because if it is thyroid, it's often completely reversible. That's a diagnosis you don't want to miss.
Absolutely life-changing potential there.
And the third takeaway.
TSH is your compass. It tells you where the problem originates. Suppressed TSH with high T4, T3 means the problem is primary in the thyroid itself or factitious. Inappropriately normal or high TSH with high T4, T3 means the problem is central, likely the pituitary. And of course, high TSH with low T4 means primary hypothyroidism. TSH directs your investigation.
It's an incredibly elegant, interconnected system.
It truly is. And that actually brings us to our final thought, something provocative for you to mull over. Think about that concept of Thyroid 6 syndrome. The body, facing overwhelming stress, chooses to lower active thyroid hormone levels to downregulate metabolism as a survival strategy.
It's a form of metabolic hibernation almost.
Exactly. It reminds us that not every abnormal lab value represents a disease state needing correction. Sometimes it represents a profound protective adaptation. Understanding the why behind the numbers, the mechanism, the context, the potential adaptation is just as critical as knowing the numbers themselves. You now have more tools to look past the surface and decipher what the body is truly telling you.
Use them wisely.
That's all the time we have for this deep dive. Thanks for joining us. We'll see you next time.